their faculties, as was initially mentioned to me as well. So it's a learning lesson for all of us, and it will be narrated by Professor Baljit Singh sir. Who else can be better to discuss this topic with us? But before we begin that topic, very important to share the Saraswati Vandana.
Saraswati Namastubhyam Varade Kamarupini Vidyarambham Karishyami Siddhir Bhavatu Me Sada.
Saraswati Ma bless all of us, and we keep excelling in our fields, especially we take anesthesiology and ISA National to higher and higher levels. As mentioned before, it's a very, very important topic today. So to discuss this topic, we have Professor Dr. Baljit Singh sir. He is currently Professor and Head Anesthesiology at SGT Medical College, Gurugram. Around 160 publications and 15 book chapters under his belt. He has been an examiner for MD, DA, DM, fellowships, DNB. He has been an assessor for National Board of Examinations, Medical Council of India, now NMC. Subject expert for UPSC and various state public service commissions, member board of directors, Indian Confederation of Healthcare Accreditation 2009 to 2018. He had been the treasurer of Indian Society for Study of Pain from 2010 to 2012. He had been member of Governing Council of ISA National from 2009 to 2011. Vice President of ISA National from 2017 to 2018, Director Scientific Committee, Indian Resuscitation Council Federation, CEO and President Designate Indian College of Anesthesiologists, and he had been listed in Marcus, Who's Health in a Healthcare 2012 edition. And dear everyone, I think it's 1/10 of the CV. It has been concise to like anything. If we keep on speaking of Professor Baljit Singh sir, it will take the entire session of today's webinar. So we wholeheartedly welcome Professor Baljit Singh sir to discuss this very important topic with all our ISA national participants. Before we begin, let me just remind you that please listen to the talk very attentively, and if you do any queries for sir, please type your queries in the chat box. We'll take all the queries and we'll address all the queries to be addressed by Baljit Singh sir. So over to you, Baljit Singh sir. You can share your slides, sir.
Thank you so much. First of all, I would like to thank the Honorary Secretary, Dr. Sukhminder Singh Bajpa, for this honor that he has given to me. And of course, Dr. Ankur Agarwal, he has very kindly, very generously introduced me, and Dr. Nishant Sahai also. Well, friends, this is one topic you don't find in books, and all that I have from my own experience, I've just compiled it for your benefit. There may be some opinions different than what I'll be saying here in this, but this is something I'm saying that it's all my own experience. Well, what is this? It's a cliff, and there's a man sitting, and some of you consider this as an equivalent to appearing in the examination. Well, let's discuss it, and then we see what it is like. Examination is a very important milestone, and it may be a life-changing experience. And to pass the examination, you need a good knowledge base that you, I believe, having read all the 3 years of your post-graduation course. You have to have a good skill base also, which you must have learned during your stay in the departments. And the third important component of clearing the examination is an impactful performance. I can't do anything about the knowledge base that you have read very well. I can't do anything about the skill base. And what I can give you are few tips which can make your performance somewhat impactful. This is a great man of science, Albert Einstein. He had said that everybody is a genius. But if you judge a fish by its ability to climb a tree, it will live its whole life believing that it is stupid. What he actually wanted to say is that the assessment should be appropriate to the knowledge and skill base of the assessee, that is the student here. It should be appropriate. What appropriate means that it should be relevant to learning. We are talking about anesthesia, and any question outside the field of anesthesia will not be a good option. Coming to skills, skills here again, these should be related to the application of knowledge for the patient care. What skills we attain, what skills we acquire during post-graduation are, starting right from intubation to CPR. That is what we call as theory examination. Here, it all depends on the ability to recall what you have read, what you have retained, organize the information and put it on paper. And the next is the practical skills demonstration, whether it is with or without, whether the examination is with or without performance skills, it varies from place to place. In this part, what is tested is the practical assessment, skill assessment, situational awareness, and the response to the given situation for the student. It may be quite intimidating because there is an examiner sitting, or examiners sitting right in front of you, and you may find it very difficult to sort of organize your thoughts and express. But well, this is something that has to be done. Examination is defined as a process in which a medical student is evaluated by a superior, whom we call as an examiner, for getting a degree to practice anesthesia. Now, during this process, the examiner determines whether or not the examinee is capable of conducting safe anesthesia independently or not. Assessment and evaluation are essential components of teaching and learning. It's important to know because without an effective evaluation, it is not possible to understand whether the students have learned, whether the teaching has been effective, and how best to improve the learning needs of the students. Assessment is a process of gathering information on students' knowledge. That can be through theory paper. Evaluation is a process of analyzing, reflecting upon, and summarizing assessment information and making judgments and or decisions based on the information that is collected from the students. What is the scope of the examination? It is to test the ability of a candidate to assess a specified medical condition for conduct of anesthesia. There is a case given to the candidate. It may be, maybe a mitral stenosis, maybe pregnancy-induced hypertension, anything. He is expected to identify, diagnose, and then, of course, conduct anesthesia as well. He should be able to take history, elicit physical signs, establish a diagnosis, and then determine the functional status of the patient and his fitness for anesthesia. Apart from that, he should be able to diagnose some very obvious medical conditions. He should be able to interpret ECG, X-ray chest, or any radiological investigation, ABG reports, blood tests, pulmonary function tests, etc. And he should have the ability to evaluate risk for surgery and anesthesia. And he should be able to discuss the management of acute emergencies. I will not say much about theory examination, just one slide. The general principles apply for theory examination, whether it is medicine or any, you must write the question number clearly on the left side. Leave a space after you answered one question. Before you start answering the second, there should be some space so that examiner can easily find out that this is a different question now. There should be headings. It makes for the examiner an easy comprehension of what the candidate is saying. Handwriting should be clear. Well, lesser the better. Diagrams, wherever necessary, diagrams speak themselves. If the examiner has a look at the diagram, which is well labeled, he understands what the candidate knows. Time your answers, you must divide the time accordingly. You can't give one question 1 hour and the remaining 9 questions for 2 hours. But never miss answering any question. You must be knowing something about that particular topic. Write a small paragraph, write a few lines. At least you will get number 1, 2, whatever. You never know. You obtain 49 marks. It is just 1 mark that you needed more to get through. So never miss answering a question. There are certain key issues of practical examination. It provides an opportunity to test skills in a realistic setting, confront the candidate with problems he may or may not have met before, to assess responsiveness and prioritization of actions to a complex situation that the candidate may be given, and to test the ability to communicate under pressure. Well, examiners are there, so there is a lot of pressure. And of course, it's a very important event for you to appear in the examination. And he should also be able to discriminate between important and trivial issues. He should focus more on what's more important and, of course, less on what are the trivial issues which can even be overlooked. There are certain advantages of practical examination. It provides direct interaction between the student and the examiner. Examiner can assess the candidate much better. It's an opportunity to take mitigating circumstances into account, flexibility in moving the candidate's strong points to other areas. The examiner is asking questions. He finds that a student is doing very well. He'll shift from that to another to see that it is not just a flash in the pan. So student has a very comprehensive knowledge of the whole subject. Then opportunity to question the candidate, how he arrived at the answer, how he arrived at the diagnosis. It's very important. Quite often it's been seen that the students somehow sniff the diagnosis during examination and then they try to fit in the finding. Well, examiner has his own ways to assess what the candidate has done. There is an opportunity for simultaneous assessment by 2 examiners. Usually the 2 examiners sit together and 2 others sit elsewhere for the cases. And they are marking independently in 2 different settings. Here the candidate is required to formulate his replies without any cues. There are no hints. This is more important for DNB candidates because if it's a MD candidate, there are 2 internal examiners. So he might slip in a bit of a hint and the candidate moves on. But for DNB candidates, there may not be many hints that will be coming along. So student has to fend for himself there. There are certain disadvantages too. Well, lack of standardized conditions. Cases that you are allotted, they may have varying difficulties. Some cases simple, some is very difficult. Patients can have varying degrees of cooperativeness. Some cooperate, some don't. There is lack of objectivity, and there can be some intrusion or any irrelevant factors which may affect the candidate's assessment. There is limited time to assess the full potential. It's just about a few hours that you are with the student, and in that you have to assess what the candidate has learned in the last 3 years of his residency. And the examiner's approach may vary. Practical examination is usually the hardest part. Well, we all are familiar. It is accompanied with a lot of anxiety. The candidate has to understand the question, think, formulate an answer, and then reply. While the examiner is looking at you, that makes the things even more difficult for the candidate. Well, stress is something which is very normal. Appearing in the examination is certainly stressful. You are in an unfamiliar setting, meeting strangers and about to interact with persons who can change the course of your life. But the stress can be healthy, that is called as positive stress, or the stress may be negative, which can affect the performance of the person. And of course, for the health of the person, it's not a very good thing to have. Well, it's very difficult to say. Now, this is an X-ray which was sent to me by one colleague of mine. Can you figure out what exactly is there here? I'll take 5 seconds here. Can you
I
figure out?
request everyone to post your answers in the chat box.
Okay, yes,
Post your
that's a
answers
good
in the
idea.
chat box.
That's a good idea. Okay, so sorry, I think I've done a mistake. I'm there, yes. Okay, so I move on from here. Well, some candidates think that this is a picture that very clearly defines their stance. The 4 examiners, after one innocent, target. I just want to dispel that myth. Examiners are not as bad as they're portrayed. They are as much humane as any kind person would be. In fact, they're your friends. However, they are given a job to do. They have a responsibility to fulfill. They have to live up to the assignment which is given by the university, by the college, by whatever. Well, friends, you love them or you hate them. The fact is that you have to face them. What do the examiners expect? They expect clinical competence. They expect that the candidate should be able to understand basic steps in clinical history, examination, investigations, differential diagnosis, and safe perioperative management of the patient. If you have covered basic points in your answers, expect to get good marks. The pattern of scoring is different for MD examination and for DNB examination. For MD examination, there is one long case which is having 100 marks. There are 2 short cases, 50 marks each. That adds up to 100 marks again. There is Viva, there are 4 stations. They have 25 marks each. So that's another 100. Total is 300. And you have to clear, you have to get 150 marks to get through. The scoring pattern varies from university to university. They may have 4 stations, 100 marks, and then Viva they may take separately. So it can be different. For DNB, the scoring is different. There are 20 OSCE stations. OSCE is objective, structured, clinical examination questions. There are 20 stations. Each is having 5 marks. That makes it 100 marks. Then there are 2 clinical cases, which is equivalent of the long cases for MD examination. So 2 cases, 50 marks each. That makes it 100 marks. Then there are 4 ward rounds, which are equivalent to the short cases. That's 4 into 15, that is 60 marks again, and 4 Viva stations, 10 marks each. That makes it 40. So total is 300. So you've got to have 150 marks to clear the examination. For OSCE, you get only 4 minutes to write an answer. You are given a sheet. You have to use only one side of the sheet. Of course, on the top, your name, your examination center, date, and everything, your roll number, and you have to write only on one side of the sheet. And these OSCEs are run virtually and uniformly, simultaneously from the National Board of Examinations Command Center, which is in Dwarka, and this is run for all the centers across the country at the same time. And the National Command Center monitors the conduct of the examination. The sheets, soon after the OSCE stations are over, they are scanned and they are sent to the National Board of Examinations within 1 hour of completing the OSCE stations. They're very particular about this. Okay, just to give you an idea of what an OSCE is like, you have a picture on the left side, and there is a stem of the question which states It's a 55-year-old man who is brought in with a history of acute left hemiparesis of 12 hours duration. And then there are 4 questions from the stem of the question. First is, what are the findings and diagnosis on this CT? Is this patient a good candidate for intravenous thrombolysis? What surgical procedure may be required in him? And the 4th is, what medication may be required to prevent recurrence? Now, difference between an OSCE and a multiple choice question, which we are all familiar with, is multiple choice question has the stem of the question. Then there are 4 answers. You have to pick which is the best in your opinion, which is the right answer. And the 3 are the kind of distractors which you have to ignore. So you have to pick one. So you get 1 mark or whatever is a mark for that. Here in this OSCE, if your initial diagnosis is wrong, and then the subsequent questions which are asked will also be wrong. Let's say a case of ECG. There is an ECG which is put up. It's a ECG of atrial fibrillation. And the candidate states it's ventricular fibrillation. So the whole management of the question will be gone. So 1, the diagnosis is wrong. The first question from that OSCE is gone. The second, the treatment is gone. Third, also is gone. 4th is also gone. So that's the major difference between the OSCE and the multiple choice question that we all know of. Okay, for clinical cases which are equivalent of a long case for MD, you are given 3 to 5 minutes for a quick history and examination. Not more than that, because the time is very limited there. And then the candidate is facing a Viva for about 20 minutes each case with a team of 2 examiners at 2 different sites. For the ward rounds, which the DNB has, there are 4 cases, 15 marks each. And these are the cases which have a very obvious diagnosis, as you can see in these pictures. There's a tracheostomy there, there is a umbilical hernia there is cleft lip and palate, and the 4th is, is a hydrocephalus. So examiner will straightway start from the Viva. From questioning, he'll start straightway. So this again is equivalent of the short cases that we have for MD examination. Then there are Viva stations, there are 4 of them. The first station, there is NSA equipment, which includes a machine. It also includes other instruments like your needles, your vagal forceps, lingoscopes, tubes, and everything. The second station has the drugs, inhalation agents, IV fluids. The third has resuscitation, difficult airway equipment. And the 4th has X-ray, all investigations, whether it's X-ray or CT scans, ECG, ABGs, capnography, and the pulmonary function test. The questions in the examinations are absolutely unstructured. There is no fixed format. Different questions may be asked for the same patient. Number of questions again is not fixed, and it depends on how fast you reply. You examiner asks some question, you replied immediately, you get marks. He keeps on asking, you keep on replying, so you get more marks. Now, if you are asked a question, you don't know the answer, then you look around, you look up, you look right side, you look left side, you look at the watch, and then you say, sir, I don't know. Well, okay, you have lost some time. He asks you second question. You again, you turn your neck right and left and waste some time. So here, the number of questions that the candidate has been put is much less. He obviously will score much less than the candidate who has answered all the questions rapidly and as clearly as possible, brief as well. That's basically the time schedule of the DNB examination. 8 to 8:30, there is report of candidates. 8:30 to 9, there is some briefing, what to do, what not to do, distribution of answer sheets. 9 to 11, it's OSCE, which is run from the National Board of Examination Command Center. A short tea break. Thereafter, there are clinical cases examination, 2 cases that I told you. Then there is a lunch break, and then the ward round and the Viva VOC. That examination finishes by 5 p.m. So that's how it is timed. Now, coming to the questions, give me a break for Just a few seconds, I'll have a glass of water. My throat is dry.
Sure, sir. Sir has brought so much of insight into as how you should be prepared for exams. That's why I'm asking everyone. It's a very good opportunity to clear your apprehensions. I've posted in the chat box also. If you have what are the things that makes you worry for appearing in the exams? What are the apprehensions? Kindly post them. It will be addressed by Baljeet sir today.
Right, Dr. Ankar, I'm back.
Yes,
Now,
sir.
coming to
Sure.
the questions, usually examiner starts with a very easy question. So don't feel offended. कि, मुझे तो बहुत ज़्यादा आता है. Examiner is insulting me by asking such simple question. It may start with ASA grading, malapathy grading, fasting guidelines, safety features of NLCA machine. Then he goes on to the moderately difficult, define COPD, pathophysiology of failure in COPD, management of eclampsia, causes of desaturation in the postoperative period. The grade of difficulty goes on increasing as the candidate keeps on answering. Then there may be difficult questions, very difficult questions, opioid receptors, role in transmission of pain impulses, physiology of one lung ventilation, why obese patients are more prone to hypoxia during induction. Well, the candidate is through with these questions also, then the candidate is given challenging questions. These questions usually are for giving the candidate more marks than the other candidates. Opioid hyperalgesia, what is the mechanism for that? Chemical structure of different drugs. He will give you a paper, he'll give you a pen, okay, draw chemical structure of this particular drug. What was in the transmitral valvular gradient in mitral stenosis? So, these are some of the challenging questions. As I told you, the grading of the questions goes on increasing as you answer them. For MD, there are two internal examiners, two external. Two internals are the ones who have been teaching you, and two externals are from outside. For DNB, all four are from outside. They are from states other than where the center of the examination is. Neither the candidates know them, nor do the examiners. So for the candidate, they are all external examiners. MD examination is always at the place of work of the student, wherever he has been working. So that's where the examination is conducted. For DNB, it is never at the place of work. It's not in the same state even where the student is working, generally so. After the COVID, there has been some changes, but still, it will never be at the place of work where the candidate is working. And the examiners are also not from the same state as that of the students. So there is a lot of strictness with regard to the process of examination in DNB examination. Now, what do you do evening before the examination? And this is more relevant for DNB examination because you will be new to the city. Do a round of the examination center an evening before because you will be new to that place, or send somebody who is accompanying you to do a recce of the place so that you know how much time will it take from the place where you are staying to reach the examination center. Collect all the material that you need to carry an evening before. All the material should be collected. Sleep early for the night. Remember one thing, the cost of lack of sleep is always higher than the little knowledge that you may possibly gain. So don't compromise on your sleep. Don't go groggy-eyed. So whatever you know, because of the heavy head, you will not be able to answer that even. On the day of examination, dress gracefully. I don't want to say what graceful dress means. You all know it. Wear an apron, of course, and put a slip on the apron which bears your roll number so that the examiner doesn't have to ask again and again, what's your roll number, what's your roll number. Things you must avoid. Well, if you're very fond of tattoos, kindly cover them up. Stained clothes, tethered clothes, ripped clothes, again, not a good choice for the day. The examiner feels that you have interests other than anesthesia, which are not which have got nothing to do with the specialty you're working for. And if you have words on clothing like this, well, you have scored a self goal. Well, this is a possible outcome. Things to avoid: clothes that reveal more than they conceal. The clothes should be weather appropriate. Avoid a dirty, crumpled apron of a colleague whose name you are trying to hide with a tape, which is peeling off, and you still display some other name. It's so obvious. It should not bear the hospital name and logo. This is very particular for DNB, not for MD. And avoid loud colors and printed fabrics, which are bizarre. To say about the physical appearance, there should be no body stretch if you are fond of them. Avoid a conspicuous shaving cut or a funky hairdo. Avoid too many bangles because they are a distraction as they jingle. Remember the cardinal rule. You don't want the examiners to remember you for your appearance, but for what you said and how you said. Arrive on time, rather before time is a good habit. 15 to 30 minutes is good enough. Don't arrive to the examination center with a baggage of books in tow, the books that you have not been able to read the last 3 years, and still you like to console yourself, okay, let me carry there. You won't have time for that. This is mainly for the DNB candidates, MD candidates, because they are quite familiar with the area, they are quite familiar with everything, so this doesn't apply as much to them. What not to carry along: coffee flasks, large stacks of food, cell phone, iPad, these will not be allowed anyway. Chewing gum, well, you keep it out. Anything that can jingle. And if you are a smoker, avoid it just before going in for the case. Don't give fumes to the examiner. Well, if you like these signet shapes, I would suggest that you kindly unload yourself and have just one or two. Don't carry a large quantity of jewelry, or don't display that much. Don't carry coins in the pocket that may tinkle as you move. Think of your appearance as a package of the product. Your appearance should convince the onlooker that, well, yes, that is a man. He appears to have something about him. That should be the kind of physical appearance. Make a good first impression. You are under judgment the moment you enter the room where the examiners are sitting. How you look and how you conduct yourself is often a precursor of things to come. Remember one thing more: you will never get a second chance to make the first impression. Now, how to make the first impression good? Seek permission before you enter the room. Enter with some air of confidence. Avoid footwear that is too noisy. A gentle smile and a good morning wish is a nice way to start. Do not sit till you are asked to sit down, and start only after you are asked to speak. Start of the day is again more relevant for the DNB students. Examiners have a short briefing session. They introduce themselves. Where have they come from? Who are they? They explain the process, do's and don'ts during the examination. The cases are allotted. For MD students, this is very normal. There are some chits which are folded, put in a small box. Those chits bear some number, 1, 2, 3, 4, 5, or whatever, depending on the number of candidates. You pull out one and you get some number. This is number 2. And there is a non-examiner coordinator who knows what is this number 2 depicting. This is usually a combination of one long case and 2 short cases. Then you are shown the cases. Okay, your long case is on bed number 4, your short cases are bed number 12 and 17. And you go. Half of the candidates take the long case first and other half take short, because sometimes the cases may be repeated. Now, how to do the case presentation? Case presentation should include key points in the history, clinical examination, investigations, differential diagnosis, and its management. Remember, case presentations make the maximum impact on your credentials to pass. So don't ignore the case presentations. A good presentation is a skill, and this differentiates a topper from a mediocre student. So if you are asked to do case presentations, grab that opportunity while you are learning. Don't skip, don't avoid this opportunity, because you may make a mistake here, it will be acceptable. But if you make a mistake there in the examinations, well, examiners may not be very kind. So don't miss the opportunity to present cases. The more you do, more confident you are, more experienced you are, more quickly you can answer, and more soundly you can answer. Long case, usually the MD candidates are given 1 hour to examine all the 3 cases, one long and 2 short. And for a long case, you are expected to write full history and your physical examination and everything. This should be recorded in detail in a small booklet of pages, small, pages, a package of pages that you are given. And this is followed by Viva for about 30 minutes for short cases and 15 minutes each for 2 short cases. So the time varies from place to place. The long is considered to be difficult. And why it is considered difficult? Because there is unstructured question. Examiner can ask anything. You may be preparing, this is a case of mitral stenosis, you may be preparing period load, after load, stenosis, how to grade the stenosis. He might start somewhere else. Then, of course, there are some easy patients, as I told you earlier. Some are very difficult. They would just not answer anything that you ask them. Some are cooperative, some are not. Case specificity may not be your favorite. This may not be a favorite area. I mean, you may not, neurosurgery, neuroanesthesia may not be your favorite area, but you have a case which is concerning that. Well, you are trapped. There can be examiner bias, examiner stringency. I may give 10 marks to the candidate for the reply. My colleague might like to give 5. He may give 15. So there is some bias, but overall, to average out, I think it's okay. And then it's a test of communication skills as well. How you organize your thoughts and how you speak them, that speaks a lot about how confident you are, one, and how knowledgeable you are. Short cases are 2 cases with an obvious diagnosis: cleft lip, hydrocephalus, cataract, tracheostomy, diabetic foot, everything. Here, you are not expected to write in detail. However, you can write 1 or 2 important points which you would like to mention to the examiner so that you don't forget it. So you can write it down. Quite often, the Viva begins with, "What is your diagnosis?" And then examiner can ask questions, how you arrived at the diagnosis. If it's not very obvious, how you arrived at the diagnosis. Give me what are the presenting features, what kind of things, what can you find on examination? So things like that. Okay, how to examine the patient. Here is examination by the student of a male patient who has been allotted to him for, say, a long case. Say hello to the patient to show your friendly approach and to win his confidence. Tell him what all you will do. ऐसा नहीं है उसको कहा, अरे बाबा लेट जा जल्दी कर. Ask him if you can examine him or her. Don't just lift his, his shirt and run your hand on his abdomen. Seek cooperation. Put him in a position of comfort. And if your language doesn't match, well, this may be for DNB candidates. Seek an interpreter who can speak the patient's language as well as your language. So patient speaks in his language, so the interpreter interprets, he conveys to you what the patient has conveyed. So likewise, it goes the other way around also. Now, if there is a female patient that you need to examine, respect her privacy. Ask for a screen. Respect her religious beliefs also. This is very important. Ask for a lady colleague or a volunteer to be with you to make the patient comfortable. Or you can even ask one of the patient's attendants to be there with you. But you still must have somebody from the hospital, some staff nurse or anyone who can accompany. To seek answers to intimate questions, seek help from the lady colleague. Don't ask yourself directly. You ask a lady colleague who's there, so tell her that I want to know this, so please ask it for me. And seek permission before you expose the patient for examination. Well, there can be situations, looking at your plight, some educated person, an educated patient may try to help you and tell you the diagnosis because he knows the diagnosis. Politely thank him for his help and say that you would still like to examine him to ensure that nothing has been missed. Now, this is a very valuable statement. How it is valuable? Well, he will happily cooperate, and more than that, you have won a lot of respect because the patient will respect. Here is a man who doesn't borrow the diagnosis given to him. He likes to make his own assessment. So there is a lot of respect that you will get from the patient, and thereafter he'll be very, very cooperative. Remember, for him, you are some doctor, one doctor in the whole hospital. But for you, he is the patient who can make a difference to your life and to your career. History taking is an art. Let the patient speak first. And if the patient is going on and on, you just interrupt briefly, seek the particular information that you ask to, that you need to know, and then lead him to the information that you are actually looking for. And then, of course, you go for physical examination. Now, before being called in for the Viva, have some sort of a brief period of mental preparation before you go for presentation. Keep off the notes that you have in your apron or you have carried in your pockets, and there will be a lot of friendly helps who try to help, but well, sometimes you will be more confused because they are trying to load you with information and your head is already going beyond it seems. Just try to cool off before you are called in. When you are called in, do greet the examiners with a gentle smile. Sit upright, look alert and interested. Don't fidget or slouch or crack knuckles or finger tapping, nothing of that. This is a sequence of case presentation, which I'm sure you all know. Chief complaints, which are the presenting complaints, which bring the patient to the hospital, history of present illness, how this present illness which has brought him to the hospital started, history of past illness, what he has been, if he has any admission in the past, whether it is because of this disease or some other disease, family history, to link if this disease has something to do with the family, personal history, well, smoker, does he drink, any addictions, medication history, if he is on some treatment, general physical examination of the whole, patient, the whole body. Then comes the system examination or the local examination with which, the patient has come to the hospital, whatever problem the patient has. Then you have a summary, probable diagnosis, and then the differential diagnosis. Sorry. Well, when you are inside the room, the presentation should be based on facts. Use simple language and articulate very clearly. There should be no jargon. Avoid being verbose. Don't use heavy words. Don't be rhyming or repetitive. Punctuate the presentation. You say a few words, give a very short pause. Presentation should be reasonably fast and polished and give the impression to the examiner that you understand the problem and know what you would like to do for that patient. After the presentation is complete, summarize the whole case, start with the chief complaints, salient features in the examination, and then comes the provisional diagnosis. The final statement after the case presentation should be, sir or madam, based on the history and clinical examination, my provisional diagnosis is this. However, I would like to rule out A, B, C, D, whatever you like to say. I will just give you a brief summary or an example of the case in, just to summarize that case. After the presentation, you would speak. A 70-year-old male presented with chief complaints of dark-colored urine, clay-colored stools, increasing yellowishness of the sclera, excessive itching. All these are suggestive of obstructive jaundice. Elderly age, decreased appetite, marked loss of weight, late onset of pain and hard nodular mass strongly are suggestive of the possibility of malignancy. Sir, my provisional diagnosis, therefore, is obstructive jaundice, possibly due to malignancy. It may be of gallbladder origin. However, I would like to rule out A, B, C, D. Now, if you have done that, believe me, the examiner will start. He has already given you 50% marks, because if somebody can sum up the case so well, he knows that he would be able to answer and he would be able to handle the question as well. So, आपके 50% marks तो almost हो गए. Presentation completed. Just relax if you can. It's examiner's turn now. Listen carefully, whatever the examiner is saying. If it is not clear to you, politely request for repeating the question. And don't fire off in the dark, because you presume that the examiner has asked this thing which may not be right. And also, don't go on monotonous speech mode. Give a brief, take a pause. Now, how to answer? Be sure of what you like to say and try to connect the two. Let me say. Try to connect these two, your mind and your tongue. As far as possible, use simple language. If you're not confident with English, ask permission to speak in the native language. Just tell him, sir, I'm not very comfortable with English. Can I speak in Hindi? I'm sure no examiner would disallow that, and nor would he deduct any marks from there. But be sure you taste words before you spit them out. It may not that you have to swallow them back. No, that would be a bad option. Coming to the Viva stations, starting with drugs. There usually are very limited number of drugs, just about 15 to 20. Prepare for 3 or 4 drugs very thoroughly. Very, very often the examiner gives a choice. Pick up any of your choice. Now here again is a bit of a trap. Avoid picking the most common drug. Why? Because everybody would pick xylocaine, bupivacaine, propofol, and by the end of the day, the examiner is sick and tired of listening to the same tune from every student. So pick up a drug which is not very rare. Say dantrolene sodium is a rare drug. You probably haven't seen that. Pick up some drug which is less commonly used. Pick up a beta blocker. Pick up something like that. But don't go, when the examiner has given you a choice, don't go for hunting on the table to pick up a drug of your choice. You keep looking around. Then the examiner asks, are you looking for xylocaine? He has kept by his side because he didn't want you to pick up xylocaine. Very grudgingly, he'll hand over you the vial and then he'll ask you questions, which, at that time, he's also maybe disinterested because he has learned a lot of xylocaine. Anesthesia machine and equipment. Most commonly asked questions are what are the safety features? You must remember all that. Examiners sometimes may be very, very strict about this. They may not tolerate that. The three divisions of the machine in the classical description, that their components. Pin and deck safety system is an important question again. Flow meters and vaporizers. So these are some of the important questions which are asked from machine. And equipment, it depends on, it's a tracheal tube, but then they would ask you how to confirm that the tracheal tube has gone in the trachea, it's not in the esophagus, the epidural needle, the spinal needle, what are the types of needles. I mean, there are n number of questions that you can have from the equipment. Resuscitation is another must-know area. There should be no margin, there's no compromise here, no margin for error. You must know the site of compression, the rate of compression, depth of sternal depression, defibrillation, cycles of 30:2, things like that. So you must learn this very, very clearly. Then come the ECGs, X-rays, capnographs, ABG reports. ECGs, again, there are just about 5 to 10 ECGs which are very commonly asked. There is arrhythmia, there is sinus bradycardia, there may be atrial fibrillation, there is MI, things like that. There may be, block. X-rays, again, there are just about 10 to 15 cases which are generally kept. Like there may be an X-ray of the, airways in the cervical region, in the chest X-ray also. He might ask you where is the airway, he might ask you for lung collapse, pneumothorax, cardiomegaly, things like that. Capnographs, you must know what is the restrictive and obstructive pattern like. ABGs, acidosis, alkalosis, metabolic, whether it is metabolic or it's respiratory, it's compensated or it's not, you must know that. Communication is another table, usually combined with recent advances and the resuscitation. This is mainly for the DMB candidates. There is one actor who is said to be the patient's relative. He is the next of kin of that patient. And you are asked to communicate to that patient, that person, that actor, that you have to take consent for the tracheostomy. And he is the person who is the relative, who is the immediate relative. And the patient cannot give consent because he is unconscious. So you will be speaking to that tracheostomy, and how you speak to that person, the examiner will assess you whether you have communicated well or not. Or the situation may be you have to inform the bad news, the patient has died, or counseling for a organ donation, or consent for immediate. There can be many situations which the candidate may be asked. But there is one actor, the person who is just acting as a patient's attendant, and you are there to inform him, you talk to him, and you seek his permission. It's very important to match your skills with the requirements of the examiner. What does the examiner need? He needs good knowledge base. He should be satisfied that yes, you know the subject well. He should be satisfied with the clinical skills that you have, your ability to apply those skills to the patient, ability to form some sort of an action plan in case of an emergency. And very important is to be aware of your limits. If you do not know a procedure and you will stay away from it, is fine. You don't know a procedure, it doesn't matter. No candidate is expected to know 100%. So, but if you don't know and jump into it, well, you have created a disaster for yourself. Don't do that. Justification of the actions, whatever you suggest, speak or do. Good communication, that's another important factor. To believe in teamwork, it's not however brilliant you may be as a worker, as a doctor, as an anesthetist. But in case you cannot be part of a teamwork, you cannot succeed. You are no good. So you must believe in the teamwork. And you must show some sort of leadership in crisis time. Something has occurred, so take responsibility of that and do best. Ask your colleagues to help you out. Divide the workload. and you should have initiative to work as well. And for all these requirements which from the examiners, you have just one, that is to pass the examination. Listen to the question very carefully while the examiner is speaking. And if you are not clear, seek clarification. Don't leave it to guesswork. So you should be very clear what the examiner wants to know from you. How to answer? Be alert to the examiner's body language. Speak clearly. Show enthusiasm to deal with the given situation. Do not take undue time to respond because the time is limited. If you don't know, just concede so that the examiner can ask another question. Now there are two options. One is, I don't know, sir. Other is, I'm not able to recall, sir. Take 10 seconds and I'll get back to you. Please give me 10 seconds more. You can type your questions in the question answer box or chat box. Now, taking these two options, I don't know, sir. It's a very blunt, crude way of saying. More than that, it shows that you have never heard of this. You just don't know. You haven't read it. The second option is, I'm not able to recall, sir. That suggests that you have read it, but you're not able to recall. Well, that's very, very normal. You are under some sort of stress. And in that state, it's quite possible that you may not be able to recall immediately. Maybe after a few seconds, you may recall it. So the second option is a better option. Avoid answering with guesswork. If at all you have to do the guesswork, defend yourself by adding, sir, I think it is so, but I don't commit it. Now in this situation, if you are right with the guesswork, you get full marks. Examiner will say, well, he is under stress. He could not really figure out completely, but he knows it. He has the answer. And if it is wrong, you don't lose anything. But in case you have answered wrongly, examiner has taken note of it. Keep your answers appropriate to the question, to the point, and brief. Do not start off on a long monologue. Remember, you get marks for the answers to the questions that are asked to you. It's quite possible that examiner asks you one question and you are going on and on and on. You have given answer to the question which the examiner was to ask subsequently. Now here you will not get those marks. You have already lost the opportunity of being asked the question that you knew because you have already answered them. Okay, avoid offering another answer as an alternate to what is asked. Examiner asks you one thing and you are answering something different. You're trading off an answer. I mean, just like in this picture, I couldn't repair your brakes, so I made your horn louder. ब्रेक तो रिपेयर हुई नहीं, मैं हॉर्न लाउड कर दिया ताकि दूसरे अपने आप बचा कर लें. Your behavior. While answering, lean forward to show interest. Keep your hands away from your face and head. Don't cover your face. That gives the impression, a very bad impression to the examiner, as if I'm torturing this candidate. Make an eye contact with the examiner, but don't stare at him. And smile occasionally, but don't go overboard. Don't grin or, well, LOL, that you are very familiar with. What creates a bad impression? Poor knowledge of the subject, you don't know much, you haven't read it. Lack of preparation, you don't know how to present the cases. Negative attitude, evasive, using excuses. Sir, I couldn't hear the murmur because there was a lot of noise in the adjoining bed. The child was crying. Well, that doesn't impress the examiner. Lack of interest and enthusiasm. Failure to give clear answers. Failure to defend your diagnosis. You have been told diagnosis by a helpful colleague, and you are trying to fit in things there, whereas the diagnosis is wrong. Or there is nothing very clear to suggest the diagnosis. Or the diagnosis made after investigation, but the symptoms, etc., are not favoring that particular diagnosis. So you are trapped. You have a lack of management plan or failure to defend creates a very bad impression. And of course, poor personal appearance as well. Do not overtalk. This includes straying from the point and monopolizing the discussion time. A good discussion is a dialogue. It's not a monologue. Do not display arrogance or super confidence. This is unprofessional and will put off the exam. Don't say, sir, no कोई problem ही नहीं है sir, कोई चक्कर ही नहीं. तो आप जितनी मर्जी difficult intuition लाओ मैं कर दूंगा. You know, you measure your words before you speak. Restrain any distracting physical habits. Do not complain about peripheral items. And very important, do not make negative references to others, including your own workplace. Sir, हमारे तो ऐसे ही होता. This is how the things are done in our place. हम क्या करें? Can't help it. Communication. Matching your communication with confidence is an important thing. Listen carefully to the question. I've already said it earlier. Avoid interrupting the examiner. Examiner is asking the question. Don't interrupt him. Even if you know the answer, hang on, wait for a while, let him complete. Don't interrupt him. Try not to use jargon in your answers or questions. And do not toot your answers again and again. Don't repeat multiple times. Being nervous is very normal in examination, and it really harms your chances because examiner understands that you are nervous. It's an important day for you, and it's a life-changing event for you. However, excessive nervousness can work against you. You have too anxiety. I mean, you have too much of anxiety. You're sweating all over in winter season. Well, that reflects that you're too nervous. Also, many people tend to be overly talkative when nervous. If you fall into that category, hold yourself. Try not to go off tangent. Stick to the question being asked and answer it concisely. Don't know it? Just politely concede and quit. There are certain lifelines which are often given by the examiner. Dr. Ankur, can I carry on for some more time? I think it will take me another 5-7 minutes.
Sir, if you're all right, you can carry on. Else, if
Yes.
you want to take a break.
No, I think I'll carry on.
Yes, sir, please carry on.
Okay.
Thank you so much.
Thank you. So sometimes there are some lifelines given. Examiner feels that, this boy knows it, but he's stuck. He's some sort of a mental block. He will give you some lifeline. He will give you some hint. Okay, can it be this? Yes, sir. Yes, sir. I mean, that if you respond like that, yes, sir, I was about to say that only. Sure, sir. Thanks. Okay. Thank you for correcting me, sir. Okay, sir, that is a better way. You have described something which the examiner feels that, not the good thing, not the best thing. So he gives you an hint. Then you can say, sir, that's better. Sure, I would like to do as suggested by you, sir. Yes, sir, that's a better idea. I fully agree, sir. In fact, it was on my mind. Well, be smart. The time of smartness these days. Well, there can be opposite. You are too confident, you are too arrogant. Examiner has given you a lifeline and you say, no, thank you, I better not. No, but thanks for your suggestion. No, I would rather not do that way. I'm sorry, but I can't. No, but thanks for your hints anyway. Sorry, I'm not in agreement with you, sir. Thanks for suggestion, but I would like to do it my way only. And the killer is this. It is quoted in Miller, page number 1129, para 2. Well, if you have done it, on the left side, you have the lifesavers. At this side, these are the killers. Never do, plead, cry, mumble, plead. Sir, मुझे pass कर देना, मेरा last chance है. Sorry. Cry, mumble, brag, talk too much, laugh out too loud, too giggly. You are acting too superior or too inferior. You are arguing. You are overconfident. You criticize your colleagues. Sir, कोई यहाँ पे help नहीं करता. They are all अपने मतलब से है, कोई नहीं हेल्प करता है। यहाँ पे तो सब खराब है, बहुत बहुत हालत खराब है, आप जानते नहीं सर। Never demean your seniors or the institution, even the colleagues. What are the common mistakes which the students often do? Inability to apply knowledge to the clinical situation that he is given, adapt to changing clinical conditions, defend decisions in a convincing manner, transmit sufficient information, indecision or incorrect decision, faulty judgment, negating examiners. I have just said, no sir, it's wrong. I can show you the book. It's just short of committing suicide. The blunders you must avoid: implanting findings. You know the diagnosis, you are trying to put the findings in which are not there. Defending the indefensible. There is no findings suggestive of what you are saying, but you are still saying, "Nee, sir, I could feel." Well, examiner feels a lot of things. Negating the examiners has already been said. So, friends, to face examiners, present yourself well, look graceful, act a professional. Very important there. Develop good presentation skills, present more cases, as many as you can. Adopt a systematic approach. Listen carefully before you speak. Measure your words. Keep your answers to the point and be brief. Communicate well. Use simple language. Avoid a confrontational approach and avoid overconfidence. Bertrand Russell had said about confidence that the whole problem with the world is that fools and fanatics are always so certain of themselves, and wiser people are so full of doubts. Always keep something to fall back on just in case it's not what you exactly thought it is. I will end with this small anecdote, which is titled "A Height of Confidence." Once, many professors were called and asked to sit in an aeroplane. After they sat, they were informed that the plane is made by their students. All of them ran out and got out of the plane except one. People asked him the reason. He said, if it's made by my student, it will not even start. So that is the height of confidence. I don't want that kind of confidence for you to have. All the best as you journey through this exam. Keep your head high and see yourself in excellence. Good luck, friends. You will ace them. And I'm sure a few days from now, I'll be sending you a message. Congratulations, you have passed your examination. Thank you so much for your patient hearing. Over to you, Dr. Ankur.
Thank you so much, sir. It's been an absolute honor. It's been an absolute privilege to listen to each of your slides. These slides, ladies and gentlemen, these slides can be made only by a man of his stature and so many years of experience. This shows the hard work and the time sir has devoted for today's session. These slides will not be found anywhere, I'm sure. It's the every lines in the slides, every graphical representations, every video which he has put, it's so self-explaining. It's amazing the way he has expressed in a span of 1 hour. It's too good. I think those who have not attended today's session must have missed something very, very valuable. That's why I request all the attendees to kindly request your students, your colleagues to watch it again on YouTube or through the link provided in the ISA website in the coming days. So
Dr.
thank you
Ankur,
so much, sir.
Thank you so much, Dr. Ankur. My teacher is there, Dr. Tej Kaur. I would request him to please, give his opinion. Sir,
Yes,
you're
sir.
muted. Sir, you're muted. Dr. Kaul, sir, you're muted.
Now
Yes,
it is okay. Good evening, Dr. Baljit.
sir, you're my teacher. Whatever I have,
I have heard your innumerable lectures in my life,
My good
spanning an
fortune, sir.
anesthesia for almost 40 years now. But this lecture I have listened from first word to the last. And I must say that this was one of the best lectures you have ever delivered.
Thank you, sir.
The importance is more because this lecture is meant for the grooming anesthesiologists, those who are going to practice anesthesiology after passing their examination after a few months or a year or so. So the importance of this lecture becomes much, much more. I remember what criteria, do's and don'ts, what should be done and what should not be done for the knowledge of the audience who are listening to me. I must tell them that I have been the, am I audible?
Yes, sir, you are.
Yes, sir, you are audible.
I must tell the audience that I have been the examiner of Dr. Baljit Singh. And when he appeared in his MD examination, I vividly remember almost all the qualities he has spoken today were there in his at that time. I am absolutely overwhelmed, Dr. Baljit, and I am proud of you that you have delivered such a fantastic lecture, which nobody will ever like to deliver. It needs tremendous understanding of the psyche of the candidate, the psyche of the examiner, the atmosphere, the knowledge, the system of examinations, and many other points associated with it. You have delivered it brilliantly. Best wishes and all
Thank
the
you.
best.
Thank you so much, sir. You've been my teacher. And whatever I am, I think is because of your teaching, your guidance. And thank you so much for your blessings. Thank you, sir. Thank you very much for very, very generous words, sir. Thank you so much.
Thank you, Professor Kaul, sir. We second each and every word of yours. We totally agree with you. Baljit, sir, with your permission, there are a couple of queries in the chat box. Apart from the positive compliments, the feedbacks, it's bombarding the chat box today because all have been benefited. Can I take those queries to you, sir?
Please do.
Sir, we all know the dictionary meaning of blunder. So, what is blunder in exam, practical exam especially, and especially for anesthesiology exams? When we go to exams, our senior would always like to say blunder mat karna bas. Our colleague would say blunder mat karna. What is this blunder in practical exams, sir?
Well, in one of the slides, I did mention what are the blunders, negating the examiners and trying to fit in the findings, trying to say something which is not there. The examiner can easily make out that you have the diagnosis with you and you are trying to fit in findings or whatever in that. So these are some of the blunders which you do. You don't examine the patient correctly. Something which is very, very obvious in the patient, which almost speaks for you. You are ignoring that and trying to say something which is not there. So these are some of the blunders which the candidates often do. The main thing is, the candidate knows the diagnosis. From somewhere he is getting that information कि ये diagnosis boss ये mitral stenosis का है. तो वो mitral stenosis की findings बीच में fit करेंगे, in one way or the other. And if the examiner just auscultates, he will just put the statue there. Within seconds, he'll be able to figure out what is there, and then you are in problem. So never do anything wrong in the examination. And if you are caught in the wrong foot, that will cost you very heavily. It's better to say, sorry, I haven't done or I do not know, than to do something which is not required. So that's what I think is a blunder.
And so the question comes from the chat box is that suppose the practical exams have started and the first 2 to 3 questions which I'm supposed to know, for example, ASA grading, Malampatti grading, and I fumble up and I do not answer these questions as per the examiner's expectations. So is this a blunder?
Well, you can't call it a blunder. I would only suggest that the initial 2-3 questions which you think haven't been answered correctly, just forget that. It is past. Now don't keep it on your head. Forget them. focus on the next question, because in case you have the weight of the questions which you have not answered to the question which you think were simple or you should have answered, that will affect your speaking for the other questions or answering other questions. So don't let that affect. It's quite often it happens that the examiner has asked something, the candidate is not able to recall. So वो थोड़े seconds के सोच के बाद कहता सर I'm sorry, I'm not able to recall. And after some time he recalls back, and if you say that, the examiner will take a good note of it. So if you haven't answered one or two or three questions, it does happen. Trust me, it does happen. Even the best of the students sometimes may not be able to recall simple questions. There is some sort of a mental block which often happens. So you got to give it to the candidate. So candidate also should not feel discouraged. कि अरे मैं तो मर गया. I mean, sorry, I'm using slang. So मैं तो गया. No, he should just look ahead to the next question. It's quite possible that he knows and he can express it well. And once you answer one or two questions, your confidence grows. What you could not answer earlier, what you could not recall earlier, you'll now be able to recall. So look ahead, look forward.
So can the candidate, after some time, for suppose he has answered 6-7 questions, can he go back to the first question or the second question which he did not answer? Can he answer it again? Sir, I have now recollected. Can it answer again?
Well, candidate can certainly say that. Examiner will not take bad note of it. I mean, if the candidate said, can I go back to the previous question, or the 3-4 questions back, you asked me this thing, can I just say a few words? And no examiner will refuse you for that, because examiner does understand that yes, candidate is under some sort of stress, so sometimes it is difficult to recall. So you certainly can go back. No problems. No harm done to you in case you do that.
Thank you so much, sir. Such a practical solution. Another query by Dr. Sunil. Especially in tackling short cases, we are not provided with the instructions as to how we should present short cases. Should we provide a detailed history, or we should point out the diagnosis and move forward?
For short cases, generally, since the time is less, so for short cases, you don't need to write, the full history, presenting complaint, present history, past history, or something like that. You, as I said earlier, you can make a note of few points which you would like to speak during the Viva, so that you don't forget. So you have just noted on the points. Quite often the examiner starts with, okay, boy, what's your diagnosis? Young lady, what's your diagnosis? So you tell, sir, my diagnosis, say it's a diabetic foot. So he will start off from there. Okay, why do you say it is diabetic foot? So you start off from there, sir, patient has history of diabetes. So like that. So for the short diagnosis, you have to make a quick look at the patient, take important points in the history from that patient to confirm that what you're thinking is absolutely right. Beyond that, you don't need to write in detail, except for few important points if you feel so.
Thank you so much, sir. Stick to the clinching points. That is what sir mentions here. Another query by Dr. Bhavna: how to deal with patients whom we cannot interpret the language, especially in DNB exams, when the atmosphere is foreign to us, when the patients are foreign to us, when we also don't get the language interpreted, then how to tackle these situations?
Dr. Bhavna, I did mention in one of the slides that this can be a problem for DNB candidates, because the candidates are shifted from one state to another. And the patients may be such that who do not know the language that you know. So there is provision. The National Board of Examination always makes a provision for interpreter availability of the interpreter. So that interpreter will talk to the patient, whatever you want to ask the patient. So you speak to the interpreter. Interpreter will speak to that patient in his or her language. He will take back the answer and give it back to you. So there is a provision for interpreter. But in case, here in this case, you are given an interpreter and there are certain findings that you have not been able to say, or certain questions that you're not able to say, the examiner will take a light view that, well, yes, the language barrier can sometimes impair, the candidate's impression about that. So the language translation may sometimes take away the essence of the question. So I think that's okay. Interpreter is available. In short, yes, interpreter is available.
So sir has cleared the point that interpreter is available as per the NBE. So do ask for interpreter if you land up in such situation. Sir, another query is regarding theory exams. We often face a situation, for example, the first two questions, if we know it very well, we keep on writing, even if it is for 10 marks. And at the end, we end up missing few questions, like one question, two questions, and that cost us very badly. So how do we write theory exam? That is one of the questions. Especially the fourth paper, the recent advances. What should we read in recent advances? That is the query, sir.
Well, with regard to the theory question, I did mention in one of the slides that please divide your time. You have 10 questions. Generally, there are 10 questions, although it varies, the practice varies from university to university. So 10 questions, you have 180 minutes, 3 hours, right? So you have 18 minutes for each question. So you try to target 15 minutes for writing down, because it takes some time for you to understand the question and then form a reply and then. So have 15 minutes. Okay, you know very well one particular question. So you, instead of 18 minutes, you spend 20 minutes on that. You know that question number 8 or question number 9 is not is something that you are not very comfortable with. You don't know much, so you will be able to write not more than 5 minutes or something. So you can utilize that time here. But remember one thing: if there are 10 marks question, there are 10 questions and 10 marks for each question. The examiner cannot give you 15 marks out of 10, because he will mark your paper only out of 10. So jitna bhi extra aap lete hain, whatever time you consume extra is on you. Examiner is going to give you marks only out of 10 questions, 10 marks. So don't spend extra time. Always a good idea to keep the watch in front so that you know how much time is gone and how much time is left. And the second one was with regard to recent advances. I don't think recent advances is very difficult. It's possible to tell these are the recent advances and these are not. Recent advances obviously are the kind of advancements which have taken place in the last 5-10 years. And in some centers it is accepted, not accepted. In some centers it's already practiced. In some centers it's still to pick up. So these are the kind of recent advances which come in.
Thank you so much, sir. That is how the marks should be addressed. Each question carries equal marks, so equal time should be addressed. In fact, some time should be spared for revisions, as what sir has mentioned. And sir has also said that institutions are carrying out policies to address to this recent advances, especially in the form of journal clubs. So, sir, you had mentioned in one of your slides that pick up any drug. If the examiner says pick up any drug, and the examinee fears that if I pick up a drug of my choice, then I might get bombarded with lot of questions. In that case, can the examinee says, sir, aap hi de do a drug. It's better you only give me the drug.
Trust me, examiners are generous people. However, the candidate might feel that they don't have a heart. I had shown you that picture in which there was no heart. So that was sent by one of the colleagues. Examiners ke to heart hota nahi. Well, that's the general impression. Leave that aside. I don't agree with that. So they are helpful. So they won't take a bad note of it. Yes, they will take a bad note if you have picked up a drug of your choice and you are not able to answer simple questions for that. So if you are picking up a drug, you must know you must have a thorough knowledge about that. Okay, there you should not fumble on simple questions. But as I said earlier, do not pick up the most commonly picked up drug. So thiopentone hai, propofol hai, muscle relaxant hai, this ketamine hai. Ketamine is very favorite. I don't know why, but well, it is. So don't pick up one of those drugs. Pick up something which is used, but not as commonly as these. Because in case you pick up that drug, examiner gets the message. Thiopentone acha pata hai, propofol he knows very well. He also knows muscle relaxants. He also knows these things which he hasn't picked up. So he is starting off from ahead. So examiner takes a positive note.
Thank you, sir. Sir, one very practical scenario. At times, you have been the examiner for so many years. There is a practical situation in which a question, if asked to an examinee, once he answers that question, the examiner doesn't agree. And the examinee keeps on insisting that this is the correct answer. Again, the examiner says, no, this is not correct. Again, the examinee, so keeps on repeating. Does it irritates the examiner? Does it carry negative marks for the examinee? When should examiner stop asking the examinee, ho gaya bas, ruk jao?
Well, my dear friend, I did mention 2-3 times. Simple answer is do not lock horns with the examiner. Okay, you can put your point. If the examiner is not convinced with that, just pull back. Array, you can't afford to annoy the examiner. Just tell, well, sir, I'm sorry, that was my impression. But as you say, I think I must be wrong. So please forgive me for that. So just quietly quit. Do not say, अगर आपने मिलर कोट कर दी, आप गए, बात खत्म होगी वहीं पे ही. आगे वाइवा का, आगे एग्जाम का कोई ज्यादा फायदा नहीं. It will only be a formality. No examiner would like to be confronted by a student during Viva. I'm not saying that examiners are always right. Okay, these are unwritten rules, that no examiner would like to be offended during that. The candidate must be smart enough to get his way through. If the examiner is not satisfied, we should just quietly pull out. I'm sorry, sir, that was my impression, but I must be wrong somewhere. Just that is the answer.
Sir, so beautifully you have addressed this question, and it's such a practical problem. It happens to everyone in the exam. Once in the lifetime, it will happen to everyone. Another query is, sir, as anesthesiologist, once we are established as an anesthesiologist after passing MD or during the postgraduate training, we are directly provided with a diagnosis, and we straight forward move on to the relevant comorbidities and all those risk factors. So why in the examination so much importance is given to detailed examination, detailed history as anesthesiologist, even though we are provided with diagnosis in the real life scenarios?
The examiner actually wants to know that you have the skill required to make a physical examination. And out of that physical examination, in combination with the history of the patient, you are able to formulate some sort of a diagnosis. And not only that you formulate a diagnosis, you have other options as well, which are going in your mind. Okay. I mean, these days investigations are in such a way that, you ask for CT, you ask for MRI, you get everything. Oh, the gallbladder, there are some stones there. You may not be able to feel the gallbladder, you may not be able to elicit other things which may be relevant in that particular case, but investigations tells you all. So the process of going through the history taking and physical examination convinces the examiner that yes, this boy, this candidate knows his art. He knows how to examine the patient. He knows how to take history. So if you don't get the diagnosis, where is the diagnosis going to come from? It is going to come from only from the history and from the physical examination. So you must be very, I would say, confident about what you're doing, and you should be very particular, very clear about how the different tests are performed on the patient. Okay, so it's important to know. Don't depend on the investigation.
Thank you so much, sir. And my last query is, when we go to exams, again, our senior colleagues or our teachers or our fellows will always say कि तुम जितना जानते हो, you drag the examiner towards your knowledge. Don't divert. जितना जानते हो वही examiner को लेते जाना. So does the examiner get influenced by examinee's point of addressing the queries?
No, examiner will take you another way. Right. So don't think that you can lead the examiner. Examiner has led many students before that. So once he knows that the candidate is going easy in this particular direction, he will take you in. His purpose is, I mean, it's not that the examiner is trying to harm the student or discredit the student. Because if he's convinced that he knows this particular area, he will leave it here and he will take you somewhere else. To understand whether the answers that you are given are not just by fluke or by chance, the candidate knows thoroughly other areas as well, which may not be related to even to the case. So if the question is asked by the examiner at that time, so it is only to assess that you have more comprehensive knowledge of the whole subject, not just about that particular case that he is referring to.
Absolutely, sir. Absolutely. So, if there are any more queries, there are still more than 100 participants. Past 8 o'clock. That itself shows the quality of the presentation and the way you have addressed all those queries. So, if you have any more queries, please raise your hand, unmute yourself, and directly put forward the question to Baljit sir.
Ankur,
Bajwas, yes, sir.
you should have told there are so many queries, recent advances. I think all the PG should know there is a journal called Indian Journal of Anesthesia. First of all, they should become the life member, associate life member of the ISA. If they become a life member of ISA, they will get the journal subscription for free. And the January 2023 issue is on the recent advances in anesthesiology. You go to that journal, you go to the ijweb.org, you explore the journal January section, and you will get to know all the recent advances. This you should have addressed. They were asking 2-3 queries from that side also. So all the PG should know that journal reading is also very important. Something you won't get into books, you get through journals also. So better go to a journal also. That is very important part.
Absolutely correct, sir. Absolutely correct. So, Madhuri ma'am, can you unmute yourself? She wants to share few words.
Yeah, good evening. I'm already unmuted. So thank you. It was a real credit. It was a real honor to hear Baljit Singh sir speak on this topic. I just want to clarify one thing, that students were asking what is a blunder. So I can give you an example.
Please.
There was a case in my experience where I asked the patient in the history taking. The student presented that the patient has normal bowel and bladder habits and urine output is normal. Then I had already examined the patient before I came and took my position in the Viva table. I knew that the patient has got a urinary catheter and a URI bag. So here I asked the student again and again, are you sure the bladder habits are normal? Are you sure the urine output is normal? So on repeatedly asking 2-3 times, the student was going on telling, yes, madam, it is normal. So that was a lie. He was telling a lie. He had not taken the history, nor had he taken the trouble to examine the patient. The urinary catheter was obvious over there. The patient had a Foley's and a URI bag, and the student had missed it. So this student was failed. Means he has not examined the patient properly. So where is the question of taking his Viva in the further part? Then one more example of a blunder, where a student, we showed him a nasopharyngeal airway and we asked him to identify it. And what did he say? He said it was an endotracheal tube. So here we start wondering whether he has intubated anybody in his life. So such a patient, such a student who cannot even identify an endotracheal tube is going to be he is going to be unsafe to the patient or unsafe to society. If we leave such a student to practice in society, he is going to create blunders himself and he is going to kill patients. So the most important thing, so this student failed. So I just want to advise that examiners don't ever come to fail you. They come, as Baljit Singh sir has already said, they come as friends. They come with a positive mind to see that you pass, because they know that you have worked very hard all these 3 years. They know. But if you do blunders like this, then only you fail. And the criteria to fail, they're not very objective like in FRCA exams or something like that. Here there are 4 examiners, and when the decision to fail a particular candidate is taken, it's a very serious decision. All 4 examiners will sit, they will again discuss about his or her performance, think and rethink, and then only the decision to fail is taken. So please do not get scared that they come to see that you fail or something like that. And one more thing is, students get confused between internal and external examiner when they sit for the exams. Of course, this is not applicable to DNB exams, as sir has already told, because in DNB, everybody is an external. But for MD, you have 2 internals and 2 externals. So the 2 internals are supposed to be your own teachers who have seen you work all the 3 years. So when you look at them, when you're facing the exam, you feel comfortable, right? Whereas when you see the externals, you get scared. So let me tell you that if I am an internal examiner, my behavior will be totally different as when I'm an external examiner. When you are an external examiner, you are literally leading. You lead all the examiners, you ask maximum questions, and the role of the internal is to give hints to the student, protect the student. For example, if an external examiner, if a student says, say I use sufentanil, okay, I use sufentanil or I use carfentanil. Students have this habit. Something which is not available, they will tell you, I use alfentanil, carfentanil. So here the external will ask, what are you using? So here the internal will help you out. No, sir, it's, tension ho jata, and we don't. Or maybe some USG guided, say, quadratus lumborum block. Okay. So you have never done it in your institute. But if the examiner asks you the question, better tell me how you do a quadratus lumborum block. So if you do not know, the internal will definitely protect you there, will tell you, no, sir, we are not yet doing it here. So that way he or she will protect you. So I just wanted to highlight the difference between the role of internal and external exam.
Thank you so much, Dr. Madhuri. I think you have added a few more points to it. Thank you so much.
Thank you so much, ma'am.
And one more thing, Ankur, something was going on regarding hints. So I'll give you an example. For example, if you have an ultrasound image, which is called as starry sky appearance, and the student is not coming out with the answer, he's not telling starry sky, you go on repeatedly asking him, then how you give a hint? We ask him, beta, do you go out in the night? Do you see the sky? Acha. He says yes. What do you see in the sky? So when that immediately that word starry sky should come in your mouth if you have read the topic. That is, if you know your topic. But a student who doesn't know the topic, he will tell moon, he will tell planets, he will tell everything, but the word starry sky will never come out of his mouth. So that is how it is judged, whether you know your topic and you are not able to answer because of your tension and anxiety. So this is an example of how students, how it is tested, whether why you're not able to answer at that particular moment. Thank you.
Correct, ma'am.
That will not be helpful in the cloudy weather, no? They will not see the stars in the cloudy weather. So it was one of the very good session today, and the teachers of teachers, Dr. Tejkal sir was here, and see the students, the next student, Dr. Baljit Singh, and then next student, us people, we are here. So it was a great learning experience from the teachers of teachers, our teachers, and now we are teachers, because we have to learn also these things, how to be good examiner. I think that part we can touch, but not involving the PG students. That can be, at least we can have a different class from Dr. Baljit Singh sir, how to be a good examiner yourself. So these are very final points sir has touched today, and everything I think has been covered in this thing. Regarding the few queries in the chat box, I already told about the recent advances. You go through the January issue of the IJA 2023. Then regarding the availability of this class, you can go and do your, whenever you get a free time during your duties in the ICU or in the operation theater, you can go to ISA NHQ at YouTube. You can get this class. You can view this class at your leisure time, at any time. So these classes are all classes are easily available on the YouTube. You can watch them anytime. This class was mainly meant because the examinations at certain places are still going on, and certain places I think they're going to start. So this was a very much a good, some encouragement tips, the very practically useful tips from sir, and he's a national examiner. So I think it's for everyone to they can again go through those points if they want to further excel in the the Viva as well as the theory parts also. Anyone wants to say something or suggest something, then we can close this session. I think people already, I think majority of the people have been answered. And we
Hello.
are, sir, Baljeet Singh sir, we are really thankful for you are sparing that special time for us.
I think
Hello.
Dr. Mohan Pathak sir wants to say something. Sir, yes, you can say, sir.
Sir, nowadays
Yeah,
they
please.
reach to the diagnosis. Basic examination of the patient, like olden days, we were taught to examine for the murmur, bronchi, blurred and everything. But nowadays they just go with the investigation like 2D ultrasound and reach to the diagnosis. So the is it expected from students, because they are managing ICUs, medical, they are in charge of the ICUs now, anesthetists. So is it expected from them to learn all this medicine examination properly, like succussion splash and everything we were taught in those days?
Baljeet sir. Yeah,
Well,
is the
I agree with him. I think it's very, very important that it's an important factor in the examiner to assess a candidate whether he can perform the general physical examination clearly. Yes, what we had learned during undergraduate courses, I think it's good enough even now. I don't think, ever since I had my undergraduate and came to post-graduation, whatever I was taught by my teachers how to examine the patient, that is quite good enough. Yes, for detailed examination, just like succussion splash or some very fine murmurs which may not be appreciable to us, of course we need help from other. We can have their services available, but I think we must be confident in our own self rather than depending on physician. उनको लेके भेजने के ओके भाई जरा देखना इसके मरमर है या नहीं है या नो काइंडली I don't think that should be a routine. Yes, for our own knowledge, to improve our knowledge, we can do that. But otherwise, we should be able to perform everything yourself. Older times, it was very, very particular. The examiners would like to see how the liver is palpated, how the candidate is doing, how the thyroid gland is palpated. It's very normal. I remember how many doctor call, how many times he would tell us कि ऐसे examine करना है, वैसे examine करना है. So we learned from our teachers and we are happy to pass it on to the youngsters. So the students must not avoid themselves from this habit, because if they think okay investigation आ गई, अरे इसमें साफ दिख रहा है, इसमें क्या करना क्या है, echo आ गई, echo में सब कुछ पता चल रहा है, तो मरमर देख के क्या करेंगे? So that's not the good approach. We should depend on our own clinical examination, must touch the patient, must talk to the patient, and must be able to elicit the physical signs.
Thanks, sir, for very appropriate answer. Thanks.
Thank you so much, sir. So if there are no more queries, then with the permission of Bajwa sir, Baljeet sir and all the attendees, can we close the session? Bajwa sir?
Yeah. I think it's quite a time is 8:15 now. So we should close now. Somebody else in chat, I don't know what they have written. Just see.
Sir, the recent lecture on pregnancy-induced hypertension, it's not available in YouTube.
It's there. You can see it's there. You have to. If not there, I will check it again. It was there. I checked it myself. Again, I will check it again.
Yes.
This will come. So Baljeet sir, thank you very much. Call sir. Last word from call sir. Then we close the session.
Of
Call
course.
sir once again.
मेरे गुरु हैं.
Sir, unmute कर लो. Call sir, unmute.
Sir, unmute.
Sir.
Sir, unmute. Sir, I kindly unmute yourself, sir. Please.
I
Yes,
said,
sir.
superb. Baljit, it has been superb. I said that it was one of the best lectures you have delivered in your life.
Thank you so much,
Nobody
sir.
to prepare a lecture like this needs tremendous knowledge and in-depth understanding of the problem of the students
Thank
and
you,
the
sir.
examiners as such.
Thank you,
Hats
sir.
off to you. It was superb.
Thank you, sir. Thank you
I
very
love
much.
to hear such lectures. I love to hear such lectures which are not written anywhere in any book.
Thank you,
These
sir.
are just experiences and your guidance to your students, what you have been doing over the years.
Thank you, sir.
Dr.
Learned a lot
Bajwa
of
is doing
things
a
from
great
you.
job. Dr. Bajwa is doing a great job.
Absolutely.
Thanks, Dr. Bajwa, Dr. Baljit, and all others, and all the organizers, the young people who have been organizing it. God bless you all.
Sir,
Thank you,
आपका
sir.
आशीर्वाद
Thank you
रहे
so much.
बस
Thank
हमेशा.
you so much. Thank you, Dr. Bajwa. Before you close it off, let me thank you profusely once again for giving me this
No, sir,
opportunity to
it's
share the
our
platform
duty
with
to have a
you.
privilege. It's our privilege,
And
sir.
thank you so much. Thanks
Thank
for
you,
the
sir.
privilege.
Thank you,
Thank
sir.
you so much, sir.
Okay.
Good night, everyone. And we
Bye-bye.
end by saying long live ISA.